So we're going to go over some of the questions because I think they're good for everybody to know. And then you have to do the answers.
Okay.
So I'll ask you the questions.
It's Dump Bin Day.
Okay, here's a
Every
good
day
one.
is that.
All right, what is borderline diabetes?
Borderline diabetes. Okay, let's say I would say 60 to 70.
No, borderline. There's no such thing.
Oh, okay.
Doesn't exist.
Oh, that's right. You're
Just
either
like
are or you aren't.
It's like borderline pregnancy.
Right. Okay.
So diabetes is defined by specific numbers. So you can't have a little diabetes or this and that. Now, there's a pre-diabetes. And so some people say, what's the difference, what's the difference between borderline diabetes and pre-diabetes? Well, there's specific numbers. So if you have a fasting blood sugar of 100 to 125, you have pre-diabetes because normal fasting blood sugar is less than 100. And I think most people don't know that. Diabetes is actually defined as a fasting blood sugar of 126 or more. And it used to be defined as 140 or more. So now more people have diabetes based on those numbers. They also changed the definition of diabetes to include A1C. So A1C is the average blood sugar over 3 months. And A1C, if you just tested that as a screening test for diabetes, then the criteria are 6.5 and higher diabetes. 5.7 to 6.4 is pre-diabetes. Totally normal is 5 or less.
So does pre-diabetes, though, mean that you are likely, if things continue the way they're going, you're likely to contract diabetes?
Yeah, about 50% get diabetes within 5 years. So it's pretty high incidence of diabetes in people that have pre-diabetes. Some people never go on to get it. And I think a lot of our patients who've been treated for pre-diabetes stay in that same range because the medications now that are available help prevent developing diabetes. They correct the underlying defect that you have. And that's why it's important to probably use medicine early and not let people get diabetes. But the insurance companies usually don't like that idea. So we just pretty much try to do it as we can.
And pre-diabetes is more likely to be tested as an A1C number or as the other?
A lot of people don't have a high fasting blood sugar, so actually the A1C is a better test. A lot of people, their sugar just goes up after they eat and they have a normal fasting. So you can't always go by fasting blood sugar. Now, if you had somebody eat a whole bunch of food and then come into the doctor's office, you might get the after meal, which for pre-diabetes is 140 to 199. So after meals, it's a different number. Diabetes is 200.
Well, that was the old trick for trying to get out of the draft. I think was to drink a bunch of sugar drinks right before you went in for your physical.
But if you don't have any problem with your blood sugar, your sugar stays the same no matter what you drink. If you drink sweet tea at McDonald's or Smithfield or something like that, which is tons of sugar, it never changes. That's what most people don't realize. When you have diabetes, it changes drastically because of defects in how you make insulin or how the insulin works. But a person with normal functioning pancreas and normal functioning everything else with blood sugar, they don't change no matter what they eat or drink. So their blood sugar might stay within a tight range of like 60 to 110 all the time, no matter what. So if you checked it after eating, it still would stay that way.
Okay, all right. What other questions did you get?
So we had some discussion about new medications for diabetes. Everybody's on different, there's so many different ones and a lot of combination drugs. When you list the individual drugs, people go, I'm not on any of those, and that's because they're on a combination. So it's hard to list every single drug there is for diabetes now, but I guess I'll have to so people know. But the newer ones are the SGLT2 inhibitors, and those are the Invokana, Farxiga, and Jardiance. So there's some discussion about those. Those pull sugar out of your body, pull calories out of your body. They keep your kidneys from holding on to sugar. So those have been a great help. They've been around for about a year now. There's also some new insulins. One insulin is inhaled insulin.
Oh, really?
Yeah, and you can puff on it before you eat.
Just like an inhaler? Just like
okay. So it's not exactly like an asthma inhaler. It's flatter. But if you take a big puff of that, that's regular short-acting insulin. And you can do that before meals. It hasn't really caught on a lot. Just because the needles now are so little and teeny that it's not a big deal. But if people were saying, well, if inhaled insulin was first before the needles, a long time ago, it might have caught on. And the inhaler is little. They tried inhaled insulin a while back, and it was a huge, like bong-shaped inhaler that you had to carry around like that big, like real big. And so this one is very small and discreet, so you can like go down under the table and do it.
All
Take a
right.
little puff.
Uh-huh.
It doesn't look like an e-cigarette though, so.
All right.
But that would be good. And that's one type of insulin that's available. And then another type is an ultra concentrated Lantus insulin, 2JO,
Mm-hmm.
and that is less volume. So if you're on a high dose of insulin, you give less volume.
Mm-hmm.
Plus, it seems to last longer. So instead of wearing off before a day's ended, it lasts pretty much the whole day. So that's another one. There's Degludec, which is called Tresiba.
Hmm.
So all these new insulins have weird names now.
Yes. I'd like to work for the company that has to come up with all the medicinal names. I mean,
The
there's
best
some-
one is
some odd-
Rhizodeg. Rhizodeg
Rhizodeg?
is an insulin now. And that's Degludec, so that's where the deg comes. I'm not sure where the rhizo comes. But it's Degludec, which is an ultra long acting insulin, and Novolog, which is short acting insulin. So you would usually give it at the biggest meal, and that way the short acting insulin would cover your biggest meal, and the Degludec would cover you through the rest of the day.
I think most people are surprised to hear that there are that many different kinds of medicines because you have to tailor it, I guess, for how.
Yeah, for individual people, and that's what I think a lot of people don't understand. I mean, they're on certain medicines, but maybe they're working and maybe they're not, and everybody's a little different. There's 300 genetic defects that cause type 2 diabetes, so there's probably going to be a different drug for every genetic defect, and so they're getting close. I mean, they're not on 300 medicines, but that's what they're trying to do is try to figure out all the genetic defects that cause diabetes and have a drug, but there's no test to see which defect you have. So you go by its symptoms. You go by, is your fasting blood sugar high? Is that the only one that's abnormal? Is your sugar after meals high, even if you eat normally, or even if you don't excessively eat carbohydrates? Is your sugar still high after eating? It's a signaling problem that your pancreas isn't working at the right time. So different drugs treat different defects. So if you know sort of when your blood sugar is the highest, that's sort of what you aim for. The trouble is people check their blood sugar mainly in the morning, which a lot of times is fine. And then they come in with an A1C, which is like their report card, and they fail because their A1C is too high. And you go, well, my sugar's really good. My meter says it's 100. The average sugar on the meter. And the meter averages, so that's worthless average.
But if you were doing that and you discovered your A1C, then you should be taking your blood sugar more often during the day.
Yes, and that's what you try to tell people. It's like, well, when do you feel tired after the evening meal? It's usually after the evening meal that's the highest, or after meals in general. So if you check it at bedtime, it might be high, then it goes down overnight when you're not eating for a while. And that's why you want to check your sugar at the highest point of the day, not the lowest. I mean, you feel better if you check it in the morning and it's good. You go, oh, I can eat whatever I want. But if your A1C comes back high, then that means that somewhere along the day it's going up. Because whenever it goes up, it sticks sugar to those red blood cells, and then you're going to measure the percentage of red cells that have sugar stuck to them. And that's what the A1C is.
Okay, all right. We'll have more to come in just a moment on Sugar Talk with Dr. K.G. Lucas with diabetes and endocrinology consultants. You can go online to find out more at beachdoctor.com. That's beachdoctor.com, and we'll have more right after this. And welcome back to Sugar Talk with Dr. K.G. Lucas, brought to you by Diabetes and Endocrinology Consultants. And we've been talking about diabetes school and a good number of people, standing room only this past Saturday. That's great. It really is good. So what other kind of questions came up?
Well, I think there's lots of concern about things on TV. The lawyer ads. Every diabetes drug has made it to a lawyer ad, I believe.
Yes.
And you have to weigh risk. I mean, there's probably side effects of every medicine, but what are the side effects of diabetes? And we try to go over the side effects of diabetes first, and if you don't treat diabetes, what happens? And we go over medications and how it takes years and years of research and clinical trials before a medication gets approved. So a lot of times, a lot of medicines don't even make it to the market because they have some kind of problem. And we went over clinical trials and the stages of trials and how, healthy people get involved in phase 1 trials. So they do it on healthy people. They give the drug to lots and lots of people before it's on the market. Sometimes you can't predict what happens after it gets on the market. But none of the diabetes drugs have been pulled from the market. There was a scare about Avandia, and the use was restricted, but it was never taken off, and now it's exonerated. And all the things about bladder cancer, diabetes causes cancer. You're more at risk for cancer of the bladder and the pancreas from diabetes, not from a medication for diabetes. So I always say, what is your risk of not treating diabetes?
Yes, right. So you got to measure. You got to measure those. I mean,
you gotta think about that, and the fact that a medicine's not going to cause you to have cancer in 6 months. You know, if a medicine's been out for a year, it's not going to cause people to have cancer. What kind of medicine is that? You know, that would be strange.
We're going to continue this next week, right? We're going to ask some more
part
about
2.
questions that come up too.
Part 2.
All right, we'll get that, and I hope you'll join us next week for Diabetes and Endocrinology Consultants, bringing you Sugar Talk with Dr. K. Jean Lucas. Find out more at beachdoctor.com. That's beachdoctor.com.